Good evening, everybody. Welcome to this latest episode of the iJournal Club, brought to you by ESCRS. This is our 10th episode. And our main aims for the Journal Club, as you know, are to improve and practice your skills in critical appraisal and also your knowledge of cataract and refractive surgical techniques. So I'd like to introduce myself. My name's Imran Yusuf. I'm an ophthalmologist based here in Oxford. And I'd like to introduce my co-host, Artemis, who's a Corneal fellow at the East Grinstead Hospital in London. And we're very lucky this evening to have two individuals on our panel who are experts in toric IOL implantation and research in those fields. We'll neither need any introduction, but Professor Rudy Nuijts is, of course, our president of the ESCRS and Professor of Ophthalmology in the Netherlands. And Nino Hirnschall is an ophthalmologist based in Austria and Vienna, who's also well established in the ESCRS organization. So I'd like to welcome both of you. Thank you very much for joining us this evening for our Journal Club.
Thank you, Imran.
Thank you for having us. Thank you.
So, of course, you may all be aware this is the paper we're going to be discussing. It's a comparison of surgical repositioning rates and outcomes for hydrophilic versus hydrophobic single-piece acrylic toric intraocular lenses. Just before we start with the poll, I'd just like to go through just a few housekeeping issues. So you might all be aware that the audience is muted throughout the presentation to avoid any background noise, but we really do encourage your participation. So please do use the Q&A button to ask questions. We will pose those to our panel. And a recording, as usual, will be available on the YouTube channel and the ESCRS Facebook page afterwards. So I'd like to hand over now to my co-host, Artemis Matsou. Thank you.
Thank you, Imran. Good evening, everyone. Welcome to this Journal Club. And thank you to our faculty for joining us tonight. We're very pleased to have you with us. We will start with some questions for our audience. Obviously, they're relevant to the paper we're discussing tonight, and we would welcome all of you to vote. This is just so we get an idea of your thoughts and how you practice and what you come across in your practice. So let's start with the first question. So, do you think that surgically induced astigmatism is an important factor in toric IOL implantation? Yes, it is important, and I know my surgically induced astigmatism. Yes, it is important, but I have not measured my surgically induced astigmatism. And no, it is not important. So what do you think? Let's see the results. Right, so all of you feel that it is important, which is very good. However, the majority feel that they have not measured their surgically induced astigmatism. Okay, we can discuss this later. Next question. How do you mark the axis prior to surgery? And we mean the axis before toric IOL implantation. Do you do it manually using ink immediately pre-op? Do you do it manually using ocular surface landmarks? Or do you use digital intraoperative system linked to preoperative corneal measurements? So what applies to your practice? Right, so most of you use ink, the traditional method, I guess, immediately preoperative, and some of you do with ocular surface landmarks, and some of you do have access to intraoperative system, digital intraoperative system. Okay, let's go for the third one. So which do you think is the most common cause of postoperative toric IOL misalignment? Is it inaccurate preoperative biometry? Is it calculation or prediction errors? Incorrect intraoperative marking, or postoperative IOL rotation? Which one do you think is the most common cause? Obviously, all of them are causes, but which one is the most common? And let's see the answer. So the majority of you think it's the postoperative IOL rotation that takes place that is to blame, and few of you think it's the calculation prediction errors and incorrect intraoperative marking. Okay. Let's move on to the next one. So at your preoperative assessment for a toric IOL, do you use the IOL manufacturer's online calculator? Do you use the online calculator plus the Baylor nomogram? Or do you use the calculator plus the Barrett toric calculator? Let's see, which one do you use? Right, so majority of you use the online calculator plus the Barrett toric calculator. Very good, so you double check your results, okay. And we can discuss this later with our panel as well. And the last question. So when choosing a toric intraocular lens, it is best to undertreat anterior with the rule astigmatism and overtreat against the rule astigmatism. Is that true or false? And let's see. So majority of you feel it is true. Okay, and again, we can ask our experts later about that during our discussion. But before we go there, I will hand back to you, Imran, for a summary of the paper. Thank you.
Okay, thank you, Artemis. So for those of you who haven't read the paper, what we're going to do is just go through it briefly with the main points from the methods, the results, and the conclusion. So of course, this is the paper we're discussing, as I mentioned earlier. And so the aims of this study were to compare a hydrophobic and a hydrophilic acrylic monofocal toric intraocular lens. And these are the brands that we used. Just by way of background, so the Oroflex is produced by a company that was sort of formed from the Aravind Eye Hospital. So this is a lens which is clearly easily available in India, whereas obviously the Acrosoft was more widely available. And what they wanted to determine was the rotational stability, or compare that between the groups following the primary implantation, determine the factors that determine that rotational stability, in other words, patient factors and ocular factors, the surgical repositioning rates in each group, and the outcomes of that surgical repositioning. Most in Europe probably use hydrophobic lenses. So this was really the comparator group, and really what the study was aiming to look at is whether hydrophilic toric IOLs compared to the hydrophobic group. So this was a retrospective study. It was a single center study performed at the Aravind Eye Hospital in India, which is obviously a famous high throughput hospital there. They acquired the data over 4 years. They included 5,529 patients. 4,600 received the Oroflex hydrophilic acrylic IOL, and 926 received the hydrophobic acrylic Acrosoft IOL. There were 28 surgeons who operated on these patients as a group. So what did they do? So in patients who presented for cataract surgery, they offered toric IOLs to anyone who had more than 1.25 diopters of against the rule astigmatism, or greater than 1.5 diopter of with the rule or oblique astigmatism. They excluded those patients who opted for multifocal toric IOLs, because of course they're only looking at monofocal torics. And they only included people who were willing or able to pay for a toric IOL. Those who were unwilling, of course, couldn't participate in the study. And then these two groups, in terms of who received the hydrophilic versus the hydrophobic, really depended on the ability of the patient to pay for the technology. So the hydrophobic acrylic IOL is an imported lens in India, and it's twice as expensive as the hydrophilic acrylic Oroflex lens, which is produced locally. So this is a key point in the allocation of the groups, which we'll discuss as we go along. So what did they do? So in the preoperative assessment, they looked at refraction, corrected distance visual acuity, keratometry, topography, and they performed an ocular assessment. They don't give any further details about exactly how that was done. At pre-op, they did manual marking at the slit lamp, and the toric IOL was aligned to that target axis. They do mention in the methods that in most cases, the axis was digitally marked using the Varion image-guided system. Otherwise, it says that limbal ink marks were manually made. It doesn't really describe about the different techniques used in each group, or how many in each group receive this particular method of marking. And post-operatively at day 1, they did a slit lamp exam, and they also did that at day 30. If there was any misalignment, they'd perform a wafer aberrometry and work out the degree of misalignment. And if the misalignment was greater than 10 degrees, they were re-examined at 2 weeks with the same techniques, including a refraction. And repositioning of the toric IOL was recommended if there was more than 15 degrees of misalignment, or greater than 2 lines of improvement expected through repositioning. So again, we can discuss what that means. The operations were principally done at 1 to 4 weeks after the first surgery. So for those who required a repositioning surgery, what they did was they did an eye trace to calculate the degree of rotation required to align the toric IOL correctly. At the additional surgery, there was no additional cost, so that shouldn't have been a factor for deciding whether to proceed to the additional operation. The existing toric IOL axis was used as the reference, and they used a manual Mendes degree gauge, which you probably all used to locate the new target axis, which was marked with limbal ink dots. And post-repositioning surgery, they were seen at day 1 and day 15. They received a visual acuity assessment, refraction, and a toric IOL axis determination, both at the slit lamp and using the eye trace. So those were the methods that were used. So what did they find? Well, I presented these tables in the order that they present the findings in the abstract. So this table, 24, but actually was quite prominent in their abstract. They compare in this table the difference between the hydrophilic and the hydrophobic group in terms of the number of patients in that group who needed repositioning following the primary surgery. You can see that 2.46% of the hydrophilic group and 1.85% of the hydrophobic group had repositioning recommended. But of course, not all of those patients ended up having the surgery. And you can see in the second column there, the percentages from each group who then did have the repositioning performed. You can see the statistical analysis shows no difference statistically between those groups in terms of recommendation or surgery performed. They also looked at the risk factors for determining who would then require a toric IOL repositioning procedure. They found a statistical significance both on the univariate analysis and on the multivariate analysis of age. In other words, a younger age group was more likely to require repositioning, and also for those who had greater than 2 diopters of pre-op astigmatism before the first surgery. Both of those factors were significant on both the univariate and the multivariate analysis. They didn't find a statistical difference by axial length, by intraocular lens power, although that was significant on the univariate, but just evaded significance on the multivariate analysis. And there was no difference in terms of the pre-op unaided distance visual acuity between the groups as a risk factor for repositioning. This is one of the figures where they show that the percentage of toric intraocular lenses, depending on the type of astigmatism where repositioning was recommended. And what you can see there is in both groups, there was more recommendation for repositioning more common with the rule astigmatism than it was with against the rule astigmatism. And you can see that's significant overall in the bottom sentence there where they compare the two statistically. For those 95 individuals who underwent surgical repositioning, they compared the unaided distance visual acuity, the residual cylinder, and the axis misalignment between the two groups. And what this table shows is that for hydrophilic versus hydrophobic, at pre-repositioning surgery and post-repositioning surgery, there was no difference in statistical tests between those two groups. Although in the abstract, which I've copied underneath, what they do here is they compare the clinical parameters before the repositioning surgery versus after the repositioning surgery. In other words, they show statistically that the surgery was successful overall, in other words, in both groups. And lastly, they also look here at the comparison of the misalignment and post-repositioning rotation based on the duration of the interval between the primary surgery and the second surgery. Essentially, what they show here is that the axis misalignment didn't differ greatly depending on the interval after the primary surgery. In other words, it tended to remain misaligned over time. And lastly, they also look here at the visual outcomes between the groups that didn't require repositioning on the right-hand side and the outcomes following repositioning surgery. And what this figure shows is that there was no difference overall in the final end result in terms of visual acuity for those who underwent repositioning surgery. In other words, they did just as well after the second surgery as the group that didn't do repositioning. Other results that they don't present in figures were that the repositioning outcomes were statistically similar in both toric IOL models, and there were no major complications or recurrent toric IOL rotation after surgical repositioning, although they do say there were 2 cases of systemic macular edema which required treatment. So just to summarize, they provide what they think they showed as new evidence in the box here. So they feel as if this is a first large series of hydrophilic acrylic monofocal toric IOLs reported demonstrated a comparable rate of repositioning with the Acrysoft hydrophobic monofocal toric. Surgical repositioning of 95 consecutive toric IOLs resulted in improved refractive and uncorrected visual outcomes with no complications. So those are the main findings. So I'm just going to stop my screen share now and hand over to Artemis, who can start presenting questions to our expert panel. And once again, do write in the Q&A button any questions that you might have, and we can pose those to our panelists. Over to you, Artemis.
Thank you, Imran. So we will start with some questions about the methodology of the paper. And the first one is for both of you, but let's start with Professor Nuijts. So obviously, this is a retrospective cohort study, and as such, it has some inherent flaws and disadvantages. But Professor, looking at the design and the methodology, have you identified any sources of potential bias that could influence the outcomes and the way we interpret the results? For example, the way the type of toric IOL was selected for each group of patients based on cost. Do you think that this adds bias, and if yes, in what way?
I think I have not spelled out completely the article, but the greatest sources of bias that could occur is that, the article title suggests that we are comparing two different materials of lenses. That's fine, actually, if they would have exactly the same design. So that means that the Aurora lens should also have that terminal hub in the haptic, like the Alcon lens has, because many of us know that, a Technis lens may resemble quite well hydrophobic toric Texas resemble the Alcon lens, but we know that the haptic ends are different for both lenses. That's why David Chang showed a difference in incidence of malrotation between the two lenses. I think a year ago or so he reported that. So I cannot see in the method section exactly how that Aurora toric lens looks in terms of haptic design. That's the first thing. But the other thing that concerns me more is that the average misalignment is around 48 or 50 degrees. Now, we have never seen that, I must honestly say. So if you say by definition it's larger than 15 degrees, and we're going to look at those cases, and that that is, and then the mean of that proportion of cases is around 50 degrees. In our series with AcrySoft lenses, we looked at this, I think 4 years ago in 300 cases. We had an incidence of more than 10 degrees or 4%. Actually, and half of these patients wanted a repositioning. So what I would like to know here is if in that proportion of cases more than 15 degrees, whether there are really mistakes. And by mistakes, I mean, if the lenses were put at 90 degrees from the original axis, because these patients should have been excluded from the series, because those are, I don't know if that's in the methodology, because those are mistakes. That's not rotation error or whatever, or behavior of the lens, but that's just a mistake. So to look at the effect of materials, hydrophilic versus hydrophobic, the mistakes made by human error in positioning should actually be excluded. And I don't know whether that has happened and to what extent. And I'm a little bit suspicious there because that figure of 50 degrees is so high.
Yeah, actually, that was one of the questions that I wanted to ask, that indeed the mean axis is quite high in both groups. It's I think the range is 10 to 90 degrees. Like that's the range.
Yeah.
The mean is 50 and 47. And even after repositioning, still the mean axis alignment obviously much better, but it's still around 5 degrees anyway in both groups. So they still have some residual.
Yeah. Yeah, then there are other potential sources of error, but that's probably not completely ethical. If I even mention those, I could envision that people who pay for it, who pay the most, are operated by the most experienced surgeons. That could be the case. I don't know, but nevertheless, the figures are comparable. But that could also be a source of error. Actually, I think.
Mm-hmm. And Nino, what do you think in terms of sources of error or bias, let's say?
Yeah. I mean, most things are said, I guess. I mean, there's just like, I never heard about the Euroflex lens. I've never heard about that one before. So I just Googled it like maybe half an hour before the journal club. And it looks a little bit like the Rayner lens, like the Superflex lens, which is very bulky haptics with the empty space in between. And because it has very bulky haptics, I think it's really, as Rudy said before, it's not really comparable to an AcrySoft lens, because it's just the design is very different. And the other point that Rudy mentioned is that if there were just like mix-ups of the flat and the steep axis, and actually you can see the answer to that if you have a look at table 1, and you see that the range of pre-op misalignment was between 10 and 88, 86, and 89 degrees. And exactly as Rudy pointed out before, that really is an indicator for the fact that some are just put in like 90 degrees off axis. And this is something that really has to be checked before you do the analysis of your data, and that has to be eliminated, of course, reported, but eliminated. So I think it's a quite important point, yes. And the other thing is that they sometimes use the variant, sometimes not. There's also something that we know that that's what Rudy's groups showed for the variant, and we showed something similar for the Callisto. So for any kind of augmented reality, that if you use these kind of devices, you might be 1-2 degrees more precise. And that's something we also have to keep in mind. As Rudy said before, it could be that those who paid for the AcrySoft lens may also got the variant, and the others did not. We don't know these kind of things. They're not mentioned. So there might be some systemic bias and methodic bias that are not mentioned in the manuscript, but might be there. Yeah.
So as a general comment, I think, or what Nino said, it's completely true. As a general comment, it's difficult to design these studies with the low incidence of complications as a randomized clinical trial, because then you need very large series, although they can have them in India, of course, but for us, it would be quite impossible to do it. But this is actually something also for registries, if you have a very bulky registry with Toric IOLs, this is something that you probably could get out of it also, and then looking in a different manner also to 10,000s of cases. Topic for Eureka, Nino.
Yeah, exactly. Yeah, true. Yeah.
Well, actually, again, this is another question. So, because I know that both of you have very extensive academic and background, and in terms of conducting a multi-center or multi-surgeon trial, because there's a lot of sources of bias, I guess, especially when it's an interventional technique and the outcome of which you measure, especially in this one. So we have 28 surgeons involved. Obviously, one of them is the high volume, but still, even so, he performed 13% of the total surgery. So there's another 87% of surgeries that were done by 27 different surgeons. So do you think that's another problem in the study, that obviously the outcomes are not, you can't really put all of them together in terms of the technique of each surgeon, the calculations, the marking, surgical induced astigmatism? What do you think?
Well, I think that, as you said, there were like 28 surgeons were involved, but they did a sub-analysis of this one guy who did most of the surgeries. I think that's fine, just to try to have an argument concerning your the validity of your data. But on the other hand, as you said, of course, it could be a difference. And that's one of the main problems, I think, of the paper, is that they cannot really have the difference between misalignment and rotation, because they did measure 1 day after surgery and 30 days after surgery. That would be rotation, of course, or especially better would be to do like a measurement at the end of the surgery when the patient is still on the table, and then 30 days after. Because we do know that there is early rotation in the first hour of surgery, after surgery, but still that would be really rotation. But what they measure is misalignment. And as you say, there's like some residents were just doing the marks not properly. Then maybe there was, I know that it did not involve residents, but only like ophthalmologists. But still, there might be some were not so trained with toric lens. So maybe there was some intraoperative bias as well. And then we also have rotation. So it's not really, what we are not measuring here is not really rotation, but just misalignment with many in between steps. And that's one of the papers that nicely showed it was from Rudy's group, from Ninkevisa, and he showed where misalignment can happen, which stage of the calculation of the marking and the implantation and the post-op rotation. And that's something that's just mixed up here, I guess, a little bit. Yeah. So it's not pure rotation that we're looking at.
And actually, looking at the poll questions that we had, and we asked the audience, what do you think is the most common source of error, of misalignment? Most of our audience believe that it's rotation, postoperative rotation. Is that your feeling as well? Is that the main cause of the misalignment?
Do you want to answer, Rudy, or should I answer? I don't know. I'm not completely convinced.
I had a long answer in the first instance. You go ahead, Nino.
Okay. Okay. So actually, I think it really depends on the power of toric lens that you're using. We just published a paper in JRS last year, and it shows that if you have a highly powered toric lens, of course, that's the main problem that we are facing. And this also has a huge impact if you have a six diopter powered toric lens, for example. But for the lower powered toric lenses, the measurement is the main problem, because we do know from several studies that if you have an astigmatism of, let's say, 0.5, 0.75 diopters, that measuring or determining the axis or the meridian of the astigmatism is much more tricky. And you might even be 30 degrees off. And that's what some papers showed also for Scheimpflug measurements. So I think for low-powered toric lenses, the main problem is the measurement. If you include it into misalignment, and if you have a look only at it, medium and highly powered toric lenses, then it's definitely the misalignment of the lens or the rotation of the lens.
Yeah. I think that the rotation, postoperative rotation, is not a very common issue, actually. If you use appropriate technology during the surgery, okay? So you take your time, especially with the Acrysoft toric IOLs, to have the lens completely unfolded, and pressurize the eye adequately. Also, that's also important, I think. And some people have the patient still lying in a supine position for some time after the surgery. We don't do that, but that's also a trick that, for instance, Thomas Cohen does. But like Nino said, I think for instance, for a 3 diopter toric IOL, if you have 10 degrees misalignment, that's around 0.6 diopters. There is not a single patient who has a problem with that, actually. So for low power lenses, I think it's not a big issue, and that's already reflected in what I said earlier. If you have 4% of patients who have more than 10 degrees of misalignment, only half of these want to have a surgical repositioning. So half of the patients say, it's not perfect, but I'm fine. It's okay. I can do with this. So that's something that you have to take into consideration also. So I think that the most important steps are in the experience that you have in the lining. And we use a bubble marker, other people use a pendulum marker or use a variant and so on. And difference between our bubble marker and variant was 2.8 versus 1.3 degrees of misalignment, but that didn't transfer to better uncorrected vision, although this was significant actually. So, but the most important message is that you should be familiar with the marking technique that you use, and you should practice it. So very simple. If you're going to use a bubble marker, use a speculum, use an eyelid holder, because I sometimes see movies of people who do this and then put the bubble marker. That's not going to work. I mean, you really have to instruct the patient properly. It should be calm, adequately anesthetized, and then put the reference marks on the eye. That's very important, I would say, as the first step. Now, I think they use their slit lamp marking from what I saw in the paper. That's a good method if you do that, of course. But everybody should do it in the same manner, properly trained, and so on.
And Imran, I think you want to ask a question as well.
And the other thing is, before I forget it, the technique of marking is that if you are going to use the intraoperative markers, you need, if you don't have digital, you need to have an instrument that has sharp endings, because if it's inked and you put it on the eye, the ink marks are going to disappear after some time, depending on the duration of the surgery. And if it's sharp, you can still see the impressions in the epithelium, and it helps you to mark. So I can envision if you have 28 surgeons, probably some of them are less and others are more experienced, that there will at least be some variety between the people, how they use that.
Yeah, it's a very good practical point. Yeah, I often find sometimes when I see people marking, the actual mark itself is about 10 degrees in diameter. So it's definitely a source of error. I just wanted to ask you both about surgically induced astigmatism, just for our audience's benefit. What are your views about it? Should people know what their own surgical induced astigmatism is? What is the importance of it in calculations for toric IOLs? Nino, can I ask you first?
Yeah, sure, of course. Well, it really depends. I think if you're an experienced surgeon, of course, you should know your surgically induced astigmatism, but only because if it's higher than 0.1 diopters, then you have to work on your technique. Yeah, so you should be below that on average. Yeah, the problem that we have is not that we induce too much corneal astigmatism on average. when you do a vector analysis. The problem is that you have a lot of spread, a lot of noise between patients. So that means it does not, at least in my hands, it doesn't really help to know your surgically induced corneal astigmatism and to put it into your formula. Because I always say temporarily, we know that our induced astigmatism is 0.06 diopters on average, 0.06. So that's not really something we have to take into account. But we do know that there's some patients where we induce more astigmatism than we would like to. And so what we have to do is, I think, is that we have, of course, we have preoperative keratometry, topography, tomography. And if we have a patient with residual astigmatism after surgery, always redo your measurements just to see if there's anything odd going on the cornea, or in the cornea, I think. But just in average, I would say that just knowing your surgically induced astigmatism, if it's low as it should be, then you do not really improve your outcomes that much. That's my opinion, at least.
Okay. One follow-up question. Sorry.
If I may add to that, in the Netherlands, we are raised in a school of superior incisions, not temporal, but we're sitting on the, and I have long legs, so there's no way for me to move in the beds that we have. And what we've done years ago is an analysis to look at the actual amount of keratometric astigmatism or the height of the K values and the relationship with surgically induced astigmatism, and there appear to be a linear relationship. So if you have let's say a 4 diopter astigmatism, the surgically induced astigmatism, at least for superior temporal position, appears to be higher than for a patient who has 1.5 diopters. So in terms of that one question that came up, what do you do with the rule of astigmatism? Are you going to undercorrect or just exactly, on try to hit it? We have a little bit of a fudge factor there that we actually undercorrect the higher the keratometric astigmatism is in with the wound patients. Because I don't know exactly how this is vectored into to Graham-Barrett's formula. We don't know that. We know that surgically induced astigmatism is in there, but how much of it is dependent on the actual height of the astigmatism, I don't know.
I've got a linked question. Obviously, there's more interest in femtosecond assisted cataract surgery. Is the astigmatism, induced astigmatism from a laser manufactured wound, does it have a less of a spread compared to the manual incision? Is that known?
I don't know. I think that, I don't know if somebody looked specifically into this. I stepped away from doing the incisions with the laser, actually. I only use the laser for the capsular access, sometimes for the lens fragmentation, but not for the incisions anymore, because some years ago, I found the placement of the incisions quite unpredictable. And that's the moment that I stopped.
Okay, interesting. Nino, do you have anything to add to that point?
We don't have the luxury of having a femtosecond laser, so it's easy for me to answer it for myself. But concerning literature, yes, exactly. I think there is not really a paper that really compares the. We do know for arcuate incisions, PCRI incisions, and so on with femtosecond lasers. We do know that the fading effect may be a little bit less concerned to manual incisions, but concerning the precision and accuracy of the incisions themselves, I think there is no paper out there. Yeah, at least to my knowledge. Yeah.
Okay. One of the questions I had was about factors that predict some repositioning. Of course, they looked at the factors between the groups, found that a young age, for example, or a high initial cylindrical error were predictive for requiring a repositioning surgery. Is that to be expected, or are there any other factors which you thought might be relevant or might be identified in that analysis?
One of the nicest outcomes there is that they found no relationship with actual length. So you have a school of people who think it is related, repositioning and misalignment is, or postoperative rotation is related to actual length, and a school of people who think it's not. We did that calculation years ago already, again, and couldn't find it. But there have been people, who have reported a relationship. Now, this is quite a huge series, I would say, probably the largest in the literature. And, they didn't find it. So I think it's primarily related to, I could envision that it is related, because Probably the longer eyes have a little bit bigger back, and so on and so on. But I think it's very important how you leave the eye when it goes off the table. And I think quite a high pressure. Take your time that the lens is completely unfolded. It's very important.
Nino, do you have anything to add to that?
Well, yeah, I mean, we did a study, I think 3 or 4 years ago, that was published in IOVS. And what we did is we did MRI measurements, so with 9 Tesla, actually quite high, 9 Tesla, and they even had an eye coil, and it was in Berlin in the Charité. And we got the images and I analyzed them, and what showed basically is that, actually that's what confirms what Rudy is saying, is that a long eye doesn't necessarily has a large capsular bag. I mean, that could depend, of course, on the density of the cataract as well, on other anatomical concepts. And there is a correlation, quite a good correlation, that long eyes have a larger capsular bag, but that's not always the case. We also had very short eyes, 22 millimeters, with quite a large capsular bag. So I think that explains why a long eye doesn't necessarily has better, lower, in this case, lower rotation stability. I mean, there's some papers out there. I know one from Matsou that was published in HEO, was in 2016. And he found that for very long eyes, it was above 28 millimeters. He did find a rotation of approximately 9 degrees compared to 3 degrees for ametropic eyes. So there's some, but these are just case series, and I think they're not big enough. Maybe that's the last word is not spoken for that one. Yeah. And I'm not sure for this study if that really answers the question, because it didn't really give any numbers what they define as a long eye, for example. Is it 25.5 millimeters? Is it 30 millimeters? We don't know that. Yeah. Yeah. Is it based on refraction? We don't know that. Yeah.
And may I ask actually further to that? So as Imran said, and as you said, axial length has been implicated in perhaps higher degrees of postoperative rotation, and also the white-to-white distance. So I don't know what you think about that, and also what do you do in your practice? Would you, for example, implant a CTR ring in these cases when you have a high myop with a toric IOL, just to be sure that it's not going to go anywhere? Or
no, I would never plan a CTR with a toric lens, because you introduce another variable that makes it unpredictable. That's one thing. The other thing is that the eyelids of the CTR could get intermingled with the terminal haptic burbs, for instance, from the acrylic lens and so on. So I personally think it would even make it worse. And I think a couple of years ago, there was a randomized clinical trial comparison with presented at ESCRS. And actually, the eyes with the CTR, if I remember correctly, were worse as the other one without Nino. I can't remember.
Yes, there was a study by Hahn, was published in BMC Ophthalmology in 2019, but I think it was presented 2018, 2017 at the ESCRS as well. And exactly, they showed no difference, no significant difference. And Hahn showed that with the CTR, they had even a little bit more rotation. Yeah, that's true. Yeah, that's true. Yeah. I mean, there are different studies out there. There's one by Matsou, and it was published in Seminars in Ophthalmology. And he showed that there would be a difference only for eyes that are really like 30 millimeters long. But I agree with Rudy. All the 2 or 3 randomized trials out there did not show a benefit of the CTR. CTR has some disadvantages. It's expensive. Okay. The second point is you may even have a little bit of a tilted lens, because it could be that one of the haptics is in front of the CTR, the other one behind the CTR, and a tilt is something we do not want to have in a toric lens. And I think prediction is less. So I would not go for a CTR. Yeah, for this case, except if it's a pseudo-exfoliation syndrome or something. But otherwise, I would not go for a CTR. Yeah.
What about the white-to-white distance? Is that relevant? Is that something that you look at?
No.
I mean, those are, as the same paper I referred to before with the MRI measurements. We also had the sulcus-to-sulcus measurements, white-to-white measurements, and so on. And they didn't really show to be very beneficial in predicting the size, so the diameter of the capsular bag. I think that there's some OCTs out there now. I'm not sure if I'm allowed to say the names, but that they have a penetration of, they have an image of 44 millimeters. So they show the cornea, the anterior chamber, and the entire lens, so the phakic at the phakic state. And they have very nice possibilities to measure the equator to equator distance, or to predict it, kind of. And they were shown to be more promising. So I think in the future we may have more of an information for toric lenses, but it's nothing that is on the market yet. Yeah.
And what about the total diameter of the implanted lens? So I think there is a small difference between Auroflex and Acrysoft. It's 1 millimeter difference. I think Nino, you published the paper on whether the total diameter of the lens has any influence on the postoperative rotation.
Yeah, exactly. Yeah, we actually. I mean, what was interesting is that the Auroflex, I didn't know that I just had, is between 12 and 12.5 millimeters. So it changes depending on the power of the lens. I find it very. I don't know if there's any other lens on the market which has this feature. Exactly, and so it is a little bit larger than the Acrysoft lens. And yes, we showed that there is a difference, but yeah, the problem is I think it's more depending on the material, it's depending on the angulation of the lens, and I think that would be tricky. But we did it with a even larger lens than that. Yes, to study. Mm-hmm. It's true.
Well, what I think you haven't addressed this yet is the issue of timing of repositioning. Actually, also, sorry.
That was the next one.
My question, really.
Oh, okay. I wait.
Well, now that you mentioned, it's actually the next question. So obviously the authors here, they had a 4-week interval to do the repositioning. Is that okay? Is that how you do in your practice? Or up until what point would you offer repositioning to a misaligned IOL?
It depends. If, like we discussed before, first of all does the patient have a problem? If the patient doesn't have a problem, I just leave it like it is. Okay, and that's in 50% of the cases. This is the case. The patient is satisfied with the result. It's probably not perfect, but he's still satisfied. And the other 50% of cases, I like to reposition quite quickly, actually, because I use the Acrysoft Toric IOLs, and what you sometimes see is that you get the imprint of the haptics in the capsular bag because of the fusion and the capsular wrapping. And in some patients that occurs quite rapidly, actually. So the longer you wait, the more difficult it becomes to release that terminal end of the haptic out of the buccal. And there are a couple of tricks to do that without creating sort of lysis and things like that. So that's a technical issue. The other issue is then if you're going to put it into the desired position, and there is already that, let's say, preformed shape of the first mal-rotated position, you always risk that the lens will rotate into that position again, because you have there that mimicked position already. So that's the reason why I would like to do that early before you get the kind of a contracted already preformed format already after 3 to 4 weeks.
Mm-hmm. Rudy, may I ask you, what is early?
Within 2 weeks.
Yeah, okay. Mm-hmm.
What is late? What's the latest?
Well, if you're going, 6 weeks and so on.
Mm-hmm.
That's for me, it's quite late. I sometimes do that, refer patients and so on. But for my own patients, where there is a problem, I like to do that within 2 weeks, not later.
Actually, yeah, we actually I just analyzed the data. It's not published yet. Where we had a look at, I think, 600 toric lenses and re-rotation rates. And at the very beginning, what happened, and we rotated maybe too early, was on the same day or one day afterwards. So patients came back maybe 1 day afterwards, or maybe 2 hours after surgery, and we said, oh, there was a misalignment, so we re-rotated at the same day or next day. And that was not a very good idea, because these are the cases that have to be re-rotated in some of the cases. So I think maybe, at least our experience, the first 1, 2, 3 days might not be the best option, but I completely agree that 1 week or 2 weeks of time after surgery is the perfect time to rotate the lens. Yeah, absolutely. Yeah. And there's not that much rotation afterwards anyhow, at least if there's no phimosis or anything of these things going on. So I think that's a good option. Yeah, true. Yeah.
We're just getting towards the end now, but just one further question about repositioning. So in this study, they tried to standardize who they would offer repositioning surgery to, and they said that either there was greater than 15 degrees of rotation, or they felt that patient might have greater than 2 lines of improvement by having a repositioning procedure. And I think you both mentioned the very high rotation in the groups that were offered surgery, 45 degrees as the mean rotation. Do you think that despite these pre-defined criteria, they probably undertreated in terms of repositioning, given the fact that the mean lens rotation in the groups that they did offer them to was very high?
Yeah, I think that could be that could be the case. I mean, at least in our hands, or our groups, this preoperative mean misalignment is not around the 45 to 50 degrees level, I must say. So if that's on average what you find, I would assume that the figure would be higher than what we have here. You know, we had what I said, a 50% acceptance of being repositioned, and that was for greater than 10 degrees. This is for greater than 15 degrees. So then already I would expect it would be higher than the 50%. And on top of that, the average is around 50. So I would think, you know, at least 75% of these patients would like to have a reposition actually. Why they don't want it, I don't know. That could be, that there could be a bias involved also, you know, of people who are not able to come again to the hospital or whatever.
Okay. Nino, do you have anything to add to that?
Well, I think it's a kind of interesting approach to say that you will rotate the lens automatically if it's more than 15 degrees rotated, because, I mean, it really depends on the power of the toric lens. If you have maybe a 6 diopter lens, then maybe 7 degrees might be too much for these patients, maybe. And if you have a very low powered lens, then 15 degrees might not be that much of a problem for some of the patients, for some it might be. So this is one of the stringent. The second point is then on how did they predict 2 lines of I don't know, of gain within after surgery. I mean, it's something, of course, you can somehow calculate it, but it's not very, I would not say it's a very academic approach, maybe clinical, I don't know. But that's very difficult for me, actually, these 2 concepts. And the third thing is what I would say is the residual astigmatism. First of all, as Rudy said before, is the happiness factor of the patient, right? So if the patient is happy, we don't touch it, of course. But the second point, that in numbers, it would be the residual astigmatism that I would take as a main point if you re-rotate the lens or not. And then I go into use astigmatism fix or whatever you use, eye trace, okay? And then you see what you can do and you show that to the patient. But yeah, that's something, at least it's our approach, yeah.
Yeah. And just one follow-up question to that. When you're doing the repositioning, do you then take the current axis versus the intended axis and only mark the difference between those 2 things?
You mean?
So we go for, sorry.
You mean like they did it in the paper, so that you have you do your, let's say, post-operative examination, then you know the axis for the misalignment, and then the axis when you have the eye fully dilated during the surgery, that position is already your, you know, your misaligned axis, and from there use the Mendes ring. That's what your question is?
Yeah, exactly.
That's what I would do, of course, because I mean that's
nothing else is relevant. Yeah.
So you wouldn't go for the refraction of the patient? I mean, that's what we do usually. We go for the refraction and check from what would be the influence of any kind of rotation that we would rotate it on the proper axis, depending on the refraction.
I mean purely to find the axis where you have to move. So you use astigmatism fix or RX formula from Gray Barrett and so on, that gives you the axis. So for instance, you know, from your examination at the slit lamp that the, you know, the position is now, or eye trace or whatever, the position is now at 67 degrees. And it has to be, using the software, it has to be at 90. So during surgery, I use that marking.
Oh, understand. Yeah, okay. Sorry, okay. Yeah, true.
That's what I mean.
Okay, understand. Yeah, completely agree, of course. Yeah, sure. Yeah. We do the same. Yeah.
Can I just also ask, so there has been a difference in this study between treating with the rule astigmatism versus against the rule astigmatism, and it seems that patients who had with the rule astigmatism treated had more rotation afterwards. Is that something that you see in your practice as well? Is the 6 o'clock rotation position more likely to get a misalignment?
I don't know if it's misalignment what they had, but
or just wrong placement.
This was a series going from 2015, I think, and we were still using the first generation software modules at the time also. So you know there will be probably more cases that had that potential for 2 lines improvement, because that was one of the criteria. It's probably not the misalignment criteria there, but it is the 2 lines improvement of uncorrected vision in these cases.
I mean, there were some papers out there. One was from Yake, in I think 2014 it was, who showed the same actually, that there was a difference between with rule astigmatism and against rule astigmatism. And I know that Li and Chang in their 2018 ophthalmology paper, they also had a look at with rule and against rule astigmatism, and they had exactly the same finding as it was in this paper. So I don't have an explanation because we don't know that much about the anatomy and the width of the capsular bag horizontally and vertically, but there might be some, I mean, at least there is some evidence because 3 papers are showing the same thing. So maybe there might be something about it, yeah.
Okay, and we have a question from the audience actually. The question is, do you adjust astigmatic power when putting low versus high power IOLs, toric IOLs?
They mean that if we adjust the surgically induced astigmatism. Is that the question? Because I don't know what...
think they probably mean if you adjust the way of your lens selection, your IOL selection.
What I said I in the beginning, we found that depending on the level of keratometric astigmatism, your surgically induced astigmatism is linearly correlated.
Mm-hmm.
So at least for the higher powered lenses with the rule astigmatism, we have the tendency to still undercorrect a little bit more, and then we don't have that with against the rule astigmatism, because we believe that in the Pericles or whatever software programs that we use, this is not fully accounted for still.
Okay. And Nino,
I'm talking about 5 or 4 higher than 4 diopters of keratometric astigmatism.
Yeah.
So the really high powered lenses.
Yeah, absolutely. Nino, is there any comments from you?
I think that's an interesting point. I mean, just again, I think that the spread and noise between patients is quite high. So I'm not sure if you're doing something good if you adjust too much for a surgically induced astigmatism for every patient, because it will be different for every patient. There's also a fading effect. We showed that others did as well within the 9 months and 12 months. So I'm not sure if I don't know what Rudy would say, that you would fully correct for this surgically induced astigmatism, that you assume at a certain toric power of the cornea. But yeah, we don't do it, at least not in our hands. I don't know, Rudy, do you do it at the moment to correct for that?
Yeah, we had in the beginning, but that was first generation formulas. We had significant overcorrections actually with the rule astigmatism, and that was much less with against the rule, because it the idea of posterior corneal astigmatism at that time, which was not fully eluded, was not clear. And that has been, compensated in the new software to some extent, but we don't know to what extent actually. And that's why I have a tendency to undercorrect a little. I don't undercorrect by 1.5 diopters or things like that. But if I have a gap of 1/2 a diopter or so with these highest power, that's no problem for me.
Okay.
All right, so I think we're probably out of time now. That was a really interesting discussion. I think we all really enjoyed it, and I hope all you participants also enjoyed it. Before you go, however, we've got a poll. We'd like to now ask for your views. So I'll hand over to Artemis for that.
Thank you, Imran. So this is our final poll, guys. So do you think that toric IOL selection according to wealth introduced significant bias that affected the validity of the study? That's according to your personal opinion. And is it yes, no, or you're not sure? That's for our audience.
It's all anonymous, so you must all vote. Use your democratic rights.
Okay, let's see. So 82% feel that yes, it has added bias to the study, to the validity of the study. Okay, that's interesting. Let's go to the next one. So do you think that there is a difference in accuracy between digital labeling of the corneal axis versus manual marking at the slit lamp? Yes, digital is more accurate. Yes, manual marking is more accurate. Or no, there's no difference between these two methods of marking the axis. So what do you think? Okay, let's see. Right, so 65% of you feel that the digital is a more accurate way of marking the astigmatism, but a fair amount of you think that there's no difference whatsoever between them. Good, okay. So very good manual marking skills. And the last question. So do you think there would likely be a significant variation amongst 88 surgeons when outcomes of toric IOL implantation are compared? yes, no, or not sure. It's one of the things that we have discussed actually tonight anyway. So do you think 28 surgeons, the variability between them would have affected the outcomes? Yes, so majority of you feel that it must have affected the outcomes, to a certain extent at least. Okay, thank you. Very good.
All right, lovely. So I'd just like to finish off by just thanking all of you for joining us for this episode. I think you agree it's been a very fruitful discussion. And in particular, I'd like to thank our panelists tonight. You can hear they're experts in the field of toric IOL implantation, and it's been fantastic to hear your views, hear the schools of thought, and hear the clear answers that you've given this evening. So thank you very much, both of you, for joining us. I'd just like to draw your attention to the next episode. So save the date, 11th of April at 8 a.m. Central European time. We're going to be discussing the effect of anti-inflammatory regimen on early postoperative inflammation after cataract surgery. So it's a newly published paper. It's made open access, so you can all download it, and you'll get a link soon to register. So do save the date. And until next time, I suppose we'll see you then, hopefully.
Thank you very much, you both.
Thank you. Thanks.
Thank you very much for joining us tonight.
Bye-bye.
Bye-bye.
Bye.
Have a good day. Bye.